Welcome, everybody, on behalf of Douglas Laboratories. Today we're joined with Dr. Penny Kendall-Reed, a naturopathic doctor who specializes in neuroendocrine health and its connection to stress and weight and metabolism. Dr. Penny Kendall-Reed studied neurobiology at McGill. She's worked successfully for over 20 years in managing neuroendocrine issues and its relationship to stress and weight with patients. In the past few years, she's expanded her toolkit with the use of genetics and how genetics can really make a difference in the outcome and greater success for a patient. So today what we're doing is a recap of stress, genetics, and the metabolism, a brief summary of key clinical points. This is a summary from our event we hosted in Portland, a live 4-hour lecture. And we're really pleased to have Dr. Penny Kendall-Reed take some time with us today and to really distill down some of the key points for us into a short version. If you attended the lecture, this will help as a reminder and recap some of the salient points. If you didn't attend the lecture, this is a very good introduction as to what one of these lectures discusses. So without further ado, I would like to hand that over to Dr. Penny Kendall-Reed.
Thank you very much for that introduction. As we saw in the lecture, weight and stress certainly continue to be two of the most clinically profound ailments that affect us today. And with respect to weight, it's not so much the people who are eating poorly and who aren't exercising. We know what to do with those people. It's the mass majority of people that are coming through our offices who are eating fairly well, they're exercising, and they're not seeing the weight come off, or they're not seeing their bodies respond to certain programs or nutritional supplements. Those are the people that we need to start to target because those are the ones that are really struggling. And this is where genetics comes in, because genetics allows us this little glimpse inside the body. It tells us, it gives us this information why one person needs a specific type of exercise, whether that be HIIT or whether that be slow, longer endurance in order to lose weight. And if they do the opposite type of exercise, it can make them gain weight. Why one type of person needs intermittent fasting to lose weight and feel healthy and feel energetic, whereas somebody else needs to eat every 5 to 6 hours or put those 3 meals in. So those are the sort of things that we're targeting today when we look at genes. And we concentrated mostly on those 4 genes. The first one of those is controlling for the production of a hormone, adiponectin. And as we saw, adiponectin is involved in a lot of different places when it comes to neurometabolic control. It helps with blood sugar stability. It helps to break down fatty acids and carbohydrates. It helps control insulin production and how sensitive the body is to hearing that. And adiponectin is, as we saw, it is produced through the adipoq gene, and the adipoq gene is mostly in the adipose tissue, but it's also in the liver, it's also in muscle, it's also in the cardiovascular system, and in the bone marrow. On that adipoq gene, there were 2 main SNPs with good clinical significance, and both of those SNPs use the A and the G allele. The first SNP was one which is associated with the actual levels and production of adiponectin in the body. And if somebody has an A allele or an AA, 1 or 2 of those A alleles, they have a much lower level production of adiponectin. So with those people, we're going to see slower weight loss, increased weight gain with less food, less control over their blood sugars, less control over insulin. The second SNP controls how much or how easily a person gains weight back after they have lost weight. And here again, this SNP uses the G and the A allele, but this time the G allele has increased weight gain after a protocol or after a weight loss program. So this gives us a clue as to when do we need to support adiponectin in somebody? Do we need to help support them during weight loss? Or do we need to help support them to maintain that weight? things that we're looking for when we're talking about adiponectin, some of the symptoms that we're going to see. Obviously, the increased weight gain and the decreased insulin sensitivity and the unstable blood sugar levels. But adiponectin also greatly affects LDL production, and it also affects inflammation. So people who have variants with the adiponectin are going to have elevated LDL levels, increased cardiovascular inflammation, a little bit stickier. And these are the people who respond really well to caloric deprivation. And as we saw in the lecture, what happens here is when people start to decrease their calories, independent of the type of calorie their bone marrow takes over and starts to increase that production of adiponectin and helps to support that weight loss. So even if we don't have access to genetic testing, we can take some of these symptoms and look at it and think, okay, adiponectin is a hormone that I should be thinking about with this patient. So then how do we support the adiponectin? One of the best ways is by using that tri-metabolic control. We also saw from the lecture that adiponectin and leptin are those sister hormones in controlling the metabolism. So we're also going to put in some carnosine because we know that carnosine helps to support the leptin. Using tri-metabolic control and carnosine, just a capsule of each, about 30 minutes before the meal will greatly regulate the leptin and adiponectin production and sensitivity. And just to recap again, what is in that tri-metabolic control, it's those three main ingredients, the dolichos biflorus, the piperbetyl, and acetyl L-carnitine, or ALCAR. These three together will help support the adiponectin, leptin, and ghrelin. Ghrelin, as we recall, is that hormone which is released from the stomach when we're hungry to increase those hunger cues. Tri-metabolic control will actually function through a lot of different genes. In the lecture, we spoke about the adipoq genes, the LEP, which is the leptin gene, LEPR, the leptin receptor gene, MC4R, and FTO. So it will help to support all of those, but it also supports a few other genes, PPARG, POMC, GLUT2, and AME1, which will be coming in upcoming lectures. But if you have experience with those genes, TriMet control can be used there. The reason it's called tri-metabolic control is because, it's affecting those three main hormones, and it's also supporting three main aspects with neurometabolic control: appetite, satiety, and that fat metabolism. Leptin is another hormone that we had a great deal of conversations about, and leptin is a hormone which we know is released from our adipose tissue at the end of a meal to say, great, I'm satisfied, I have enough fuel sources, let's start fat burning. And it does that by increasing the production of alpha MSH, which then inhibits neuropeptide Y, and that binds into that MC4R receptor. And that controls our satiety and then stimulates our initiation of the metabolic functioning. Like the adipoq gene, there are two sites on the LEPR gene, and this is the leptin receptor gene. The first site, it controls how many leptin receptors we actually have, the expression of the proteins to increase the sensitivity of those receptors. And here the C allele is associated with a much lower metabolic rate as opposed to the G allele because we have less functioning proteins and less receptors. The second site on the LEPR gene deals with how somebody craves snacking and food-seeking behaviors in between meals. Leptin, as we know, because it's a satiety hormone, on the second site, these patients who have a G allele have a very, very difficult time, not so much with the hunger, it's more the food craving and that seeking behavior as compared to the A allele, particularly after 6 p.m. on. We also have an LEP gene, and this codes for the production and the onset of leptin itself. With the LEP gene, these patients have had when they have a mutation, and the mutation here is the A allele. These are the patients with very early onset, almost morbid obesity. These are the childhood obesity. They have a great deal of hunger. They also have a great deal of decreased ATP production, so reduced energy expenditure, because their brain is not getting that message of I'm done, so it doesn't tip off metabolic functioning. We have a lowered ATP production. And we also have a lot of dysfunction within the gonadism system because our pituitary is greatly affected by leptin as well. What do we see with these patients? They're never satisfied. These are the patients that at the end of the meal, they're going back to the fridge, they're going back to the cupboards, they're looking for something else to eat. And it's not because they're hungry, but their brain just doesn't get that I'm done message, so it's continually seeking out the food. What they crave is actually non-specific. Again, it's they could have the chips or the chocolate or rice. They'll just really gravitate towards anything to keep eating. They just have that desire to keep eating. It's definitely worse after 6 p.m. because we know that leptin should be most active after 6 p.m. to quell our hunger and our food cravings so that we can have a good sleep all night long. And these people will have a very slow weight loss. So once again, if we don't have access to genetic testing, we can take a look at these symptoms with our patients and think, okay, should I think about treating leptin? And if we do, what are we going to do about it? We're going to start with that amino acid carnosine because we know that a minimum of 300 milligrams, again, 30 minutes before meals, will really help to support leptin production and inhibit leptin resistance. It will never push leptin above normal. Again, tag teaming that with the trimetabolic control not only helps to support the leptin, but will also help to support the adiponectin, which when those two hormones are in balance together, the metabolism is at its absolute best. Resveratrol is also something that we can put in temporarily, just about 200 milligrams or so twice a day on an empty stomach. It can be mixed with the carnosine and the trimet control. The resveratrol will help to increase uncoupled protein. It helps to reverse lipogenesis, increase the fat burning. Because those leptin patients have a slower metabolic rate, this is just giving them a little bit extra support while we're doing some of that genetic retraining. The next gene that we spoke about was the MC4R receptor, and this is the melanocortin-4 receptor. And what this does is it binds either alpha MSH, which comes from the leptin to say, great, I'm done, I have enough fuel sources, let's start fat burning. Or when we don't have enough fuel sources and we haven't eaten enough, ghrelin then from our stomach stimulates the production of a agouti-related peptide, which also binds into the MC4R competitively with the alpha MSH. So we either stimulate satiety or we stimulate hunger, and all of that is controlled through the MC4R receptor or the MC4R gene. MC4R also has a large impact on the rate of our metabolism, as well as sexual behavior and desire and libido, and functioning of men's erections. Mutations in this gene, again, we'll see a lot of weight gain, easy weight gain, alterations in insulin levels. These are the people also, though, that have a great response of weight gain to certain drugs, particularly antipsychotics as well as antidepressants. And again, we see a variation in a lot of weight gain with certain drugs. And if you have a patient that has a rapid weight gain, again, without changing diet or exercise, when they go on an antipsychotic or an antidepressant, most often MC4R is one of the reasons why. Having even just one variant in this SNP, one C allele, actually accounts for an 8% increase in obesity. If they're homozygote for this variant, meaning a CC, there's a body fat increase by up to 43%, and this is without any of the changes in diet and exercise alone. So it's a really, really important SNP that also interacts greatly with the other SNPs. So what do we see here? This is a person who is hungry all the time. When we have that SNP, ghrelin is winning out, so that AGRP is winning out all the time over alpha MSH. So they're truly hungry all the time. Very irregular or low libido and sexual behavior, very, very slow weight loss, and again, that great weight gain with antipsychotics. So what we're going to do here is, again, support that rate of fat burning with fixing the adiponectin and the leptin, because we also want that leptin to help increase alpha MSH and fight that ghrelin. So we're going to use that trimetabolic control, 1 capsule 30 minutes or so before meals. One of the best ways to inhibit agouti-related peptide is with calcium magnesium, something we already need anyways. My favorite here is the CalMag 2001 because we want 2 parts calcium to get at that agouti-related peptide. Just 2 a day with food. And then we really want to support the stress response here. As we saw in the lecture, elevated cortisol levels or stress levels can actually alter our genes expression and push all genes into their variant position. That's particularly so with MC4R. We also saw how cortisol decreases the rate of fat burning itself, increases the rate of lipogenesis, has a huge profound effect on adipogenesis. So using Serotonin Plus to regulate out the HPA axis, regulate out cortisol, adrenaline, and noradrenaline productions helps to support MC4R, but also all of our genes. FTO is one of the final genes that we spoke about. And FTO has one of the first fat genes. It's called our fat obesity gene, with a lot of great research behind it. This is one gene that, although it does affect greatly our metabolism, it has more to do with food cravings for energy-dense foods, both those sugars and those fats. And it also has a great deal, particularly as we age, in the conversion of immature fat cells into our mature white adipose tissue or the brown adipose tissue. People who are A alleles, which is the variant allele, they'll like to take all those immature adipocytes and push them all into WAT, the type of fat that we don't want, the inflammatory fat. Versus the T allele will take a lot of those adipocytes, immature ones, and push them into BAT, the brown thermogenic fat. FTO also has a regulatory control on leptin and adiponectin through that Iroquois 3 and 5. So again, the A allele has a very difficult time producing adequate levels of adiponectin and leptin. We see a lot of low satiety with the A allele, but one of the great things that we see in terms of regulating out FTO is that unlike a lot of the other genes, FTO responds really, really well to diet and exercise, and much more so actually than supplements. What we will see with these people is a great craving for fats and sweets simultaneously, but when they avoid those, there's a great reduction in weight loss. When FTO, who is actually extremely efficient at using their calories, so they actually don't need as many calories even though they crave the calories, when they do a lower calorie or higher protein diet, you'll see a good response with weight. However, when they deviate even slightly from the diet, you will see rapid weight gain, and they also have increased hunger. So how are we going to support this? We're going to target that leptin again and adiponectin because the FTO A allele doesn't produce them adequately. So we use that combination of the L-carnosine and the trimetabolic control 30 minutes before meals. But what we want to do is move these people to more of an intermittent fasting, high lean protein, lower simple carbohydrate diet. So with the intermittent fasting, we're in an ideal world, we're going to look at sort of around 14 to 16 hours from dinner to the first meal, keeping in a coffee. To help maintain that, using some fiber to stretch the stomach and trigger the stretch receptors in the stomach, which then inhibits the production of ghrelin, is a really key way of helping these people initiate this dietary protocol. So using fibers like the pure lean fiber is an extremely healthy way, also great for the bowels, but a great way to get those stretch receptors going. Using really clean, lean proteins. Again, we can use the pure lean protein. If we want a vegan source, we can use the whey basics and the clean protein to help maintain a really high protein, lower calorie diet. It's not to say we're not going to use the chickens and the fish and the turkey, but because these people need an even lower calorie and a very lean protein diet, this is a great adjunct to add into that diet. Controlling all of these is also really key with making sure that our adrenals are in their correct position. Because again, when we hypersecrete that cortisol, it's going to push all of those genes to their adverse position. So we know that we have sort of 2 levels of adrenal dysfunction. It can either be a little overdrive or overfunctioning, or a little bit underdrive, the low adrenal. So one way that we can take a look at it is measuring our orthostatic blood pressure, which textbook perfect under normal conditions should be around +10. So when we go from lying to standing, both the systolic and diastolic blood pressure go up by 10. If it goes up by 15 or more, we know that the adrenals are starting to ramp themselves up and go into overdrive. This is where we produce high levels of all three glucocorticoids. We have the adrenaline, noradrenaline, and the cortisol. The symptoms that go along with this are the racing thoughts, the difficulty falling asleep, waking between 2 to 4 in the morning, a lot more anxious symptoms, a lot of heart palpitations, and even sweats. So what are we going to do with this? We're going to reset that lost feedback in that HPA axis, and we're going to lower that excess release of the glucocorticoids with the Serotonin Plus. We're going to use 1 or 2 of them twice a day on an empty stomach. These people, as we know, have blocked melatonin production from the pineal gland, which is also why they're not going into stage 4 sleep, not getting that rest. So we're going to use the melatonin anywhere between 3 to 9 milligrams. Prefer the PR version, the time released, so that they get a good stage 4 sleep all throughout the night. We're going to use Sedatal Plus here. Again, a natural sedative that won't make us groggy when we wake up. If falling asleep is a problem for these people, we'll use 2 before bed. If they're waking between 2 to 4 in the morning, we're going to use 1 in the middle of the night. The faster we can retrain their sleep, the faster the adrenals are going to normalize themselves. And GABA is also something that we can use twice a day, which has a calming effect on the body, but also taken before bed will help to moderate out the amygdala integration. And as we saw in the lecture, what the amygdala does at night is reprioritizes everything that happened during the day. And when we wake up in the morning and our body has emotionally and mentally let go of all of the stressors from the prior day that it didn't need to hold on to, that in itself supports the adrenals and lowers the cortisol response. What do we see again with on the other side of the adrenal spectrum when we have a lower adrenal output? This is where the orthostatic blood pressure only goes up 5 points or even falls like 5 or 6 points on standing. These are the people who have very low or flat-lined or even reverse curved cortisol. So low in the morning and start to increase at night. They have very low adrenaline and noradrenaline. So they're the people that are tired all the time. They get the lightheaded on standing because they're not getting an adequate vasoconstriction with the adrenaline, noradrenaline because it's so low. These are the patients that sort of mimics a thyroid picture where they're sleeping 8, 9, 10 hours a night, but because they're not going into any stage 4 sleep, they're still waking exhausted. So with these people, they still have that lost feedback within the HPA axis. So we still need to use the Serotonin Plus. But here it's been going on a little bit longer, so we're going to start with a higher dose of 2 twice a day and then gradually decrease it to 1 twice a day, again always on an empty stomach. Unlike the overdriven adrenal condition, here we need to support and boost up the adrenal gland itself, getting them making some adrenaline, noradrenaline again. So we're going to use the Adrenal Plus, which has the glandular, a much faster route at boosting it. Or if we have a vegan patient, we're going to use the Adrenamend, the adaptogenic version, 2 caps twice a day here. Just recognizing it's going to take a little bit longer to boost things up with the adaptogen versus the glandular. We also need to get them back into that stage 4 sleep where we heal. And here we're going to start again with a higher dose. We're not even going to start with the 3 milligrams. We're going to go straight to the 6 or the 9 because it's been a much longer period of time that they have been out of stage 4 sleep and needing to get back into that regular sleep pattern. So we can see that controlling weight is far less about diet and exercise, not that we can negate that completely, but so much more about what our hormones are doing with our food and our exercise. And what's controlling our hormones is our genes. The beauty of it is that we have a way that we can also help to control our genes and get better control over our health and our life.
I would like to thank Dr. Kendall-Reed for this valuable recap from the in-depth educational event from a few weeks ago. We really appreciate your time and knowledge on this topic. For more information or information on more in-depth training and educational events, or to watch a webinar with more detail on this topic, please visit douglaslabs.com. Thank you for joining.